Now, our next speaker, Professor Marie Fallon, is the St Columba's Hospice Chair of Palliative Medicine at the University of Edinburgh and a consultant in palliative care at the Western General Hospital in Edinburgh, and a great colleague of mine. She has decades of experience caring for people at the end of life whose care is particularly difficult. She edits the Oxford textbook of palliative medicine, as well as the ABC of palliative care for medical students. Speaking several languages, she is also internationally renowned for research, which provides evidence of how to best help people who are experiencing distress or total pain at the end of life. She is creating a sound evidence base showing how palliative care can help anyone with a life-threatening illness. Marie, you are most welcome. Please unmute your mic, switch on your camera, and we are looking forward very much to hear your perspective. Thank you.
Thank you so much, Scott. Thank you. And I would like very much to spend the next 20 minutes really focusing on the evidence base for care of all patients, the evidence base for the significant gaps in that care, the understanding of what civil society actually understand by assisted dying, and that relationship of assisted dying to the care of all patients and also to palliative care services, using in particular the Canadian model, given that Canada is in fact, an English-speaking country and has a very similar healthcare system to our own. I'd also like to end by looking at the non-medical model of assisted dying and summarising what we've actually learned from actually a significant body of evidence out there that I think has been summarised very eloquently by Tani. So we know that palliative care is associated with better quality of life and symptom burden, more home deaths, fewer emergency department attendances, which can be very distressing at the end of life, and is cost-saving or cost-neutral within the general healthcare service. So value is excellent, quality is excellent, and there are potential cost savings. So we'll park that just now. If we move on, though, to the provision of palliative care in the UK, there's ample evidence that's indisputable that actually provision is inadequate. And at least 100,000 people, but significantly more in the UK, die each year needing palliative care, but not actually receiving it. And this is very much an underestimate. So we know that palliative care can improve care for many patients. However, there's indisputable evidence that a significant number of people, and this will work out to over 300 patients a day who should be receiving palliative care, do not actually have access to it. Now, the other worrying issue is that the provision of palliative care in the UK is unequal. And sadly, there's a linear association between greater area deprivation and not receiving palliative care. I'm sad to say that I see this in my own practice, which deals with very difficult to control symptoms. And I would say very clearly that this is the issue. In those patients with greater deprivation are least likely to access palliative care. We also know that socioeconomically deprived groups are increasingly less likely to die in hospices. And there are a lot of sequelae of that. So there are strong associations between deprivation and inequity and very poor access to palliative care. And the other inequity is, of course, patients with cancer are more likely to have access to palliative care than patients with other life-limiting terminal illnesses. That said, the duration within palliative care is 53 days, median of 53 days for patients with cancer, and just 27 with other illnesses. If we've got time, we might come back to this point, but actually, given that cancer is associated with a huge burden of symptoms over many years, in many patients, it really can be a chronic illness. 53 days with optimum palliative and supportive care is very little in the grander scale of things. And there is a dictum in that patients will often die the way they've been cared for in the last months and years of life. And we can't expect to put things right in the last 24 hours if patients actually have been suffering for many months or even longer. So the whole area of access to palliative care is really is poor in the UK, and that has been recognised in a number of ways. Now, the number of patients, if we look at Scotland alone, that are projected to need palliative care by 2040 is going to increase by up to 20%. So the problems that we have currently with poor access to palliative care, and particularly in those from socially deprived situations, this is going to increase by up to a fifth. So these are very worrying data. However, from the point of view of UK health and social care policies, although palliative and end-of-life care is barely mentioned, three themes that are prominent are integrated care, personalised care, and support for carers, which of course are all part of palliative care, which has an evidence-based approach to each of these. Now, in contrast to the evidence for palliative care, albeit in the UK, not all patients get access to it, the evidence for assisted dying is very sparse. And Tani alluded to the very important report of the Lancet Commission on the Value of Death, recently published, which I would recommend that you all look at. There's much that we don't know about assisted dying, and there's a very clear call for more research. And I really believe this very strongly. We're potentially diving into a big black hole, and we've got no idea what's at the bottom. And this list here really outlines some of the areas that we have no answers to. We need to look at, ranging from societal costs, relationship to suicide rates, underground practices, is trust in doctors affected? We'll come back to that when looking at the Canadian data. What safeguarding measures are needed? And some people would say that there are no safeguarding measures that are actually infallible enough. However, all of these questions are so fundamental. We would never consider any other intervention in healthcare on the basis of the evidence available for assisted dying. It just wouldn't get past the very first pre-hurdle. And yet we're at a point where we're not even talking about evidence, really. So the fundamental of evidence is lacking. From the point of view of specialist doctors, because if we are looking at integration within healthcare, then presumably clinicians would have to be involved in it, as in Canada and other countries. You can see that the majority of clinicians are actually opposed to assisted dying. It becomes more prominent once you get to, oncology, geriatric medicine, and palliative medicine. But you can see that there's a range there. So there's a practical issue. This, of course, is even more exaggerated when it comes to the question of, would you actually deliver assisted dying yourself? Would you be involved in it? And of course, the majority of doctors will say no. There are a lot of important questions. Safeguards we've mentioned. How safe is safe? Eligibility. Might this be broadened? We'll come to that when we look at the Canadian data. What systems of monitoring would be effective and appropriate? Again, the Canadian data shows that that's already failing. And what are the potential consequences of palliative care? And we'll look at that in some detail. I think one of the fundamental issues is, we all want to do the very best for the greatest number of people possible. I mean, this is a universal truth. And unless you're a very strange outlier, that's how it is. That's how human nature is. And within that, we have to remember that legalizing assisted dying, it won't just affect the small number of people who actually want it, but it will affect many people living with a terminal illness. And again, I'll show you the evidence of that from Canada, which is very clear. The impact on services for all patients is clear. So this is an interesting phenomenon in that when we look at public opinion polls, we find high levels of support for assisted dying. But actually, public opinion polls are poor instruments for any complex topic, but they're particularly poor instruments for something that is using quite confusing terminology. So when the relevant complexities are incorporated into the public opinion polls in assisted dying, support does drop and 42% of people changed their mind. But if you look at the figure on the right, what do you understand by the term assisted dying? You can actually see that 42% of the population thought that giving people who are dying the right to stop life-prolonging treatment was what we meant by assisted dying. And in fact, the majority of people actually thought that assisted dying referred to areas that are already legal, such as the right to stop life-prolonging treatment. So there's even mixing up with palliative care. Some people thought that, actually providing hospice type care to people who are dying, 10% thought that that was in fact assisted dying. So the whole area is in fact a mess. So let's look at the evidence, and Tani was able to cover a vast amount of this, and I'm just going to give you a few of the headlines. So if we actually look at Belgium, so assisted suicide and euthanasia has been legal there since 2002. And logic assumes that they'll be closely adhering to the law. As Tani's already alluded to, the reality is there are very serious shortcomings in both the practice and the application of the law. Current practice in Belgium with recent regulations means that no one can opt out of providing assisted dying under any circumstance. So there's expanding eligibility criteria. And as with other countries where assisted dying is in the legislation, there's been a deterioration in the provision of end-of-life care, palliative care services. So Belgium is 26 in end-of-life care ranking, and that's actually down 21 places since 2015. And I think if you could just hold on to that fact, because this is a bit of a recurrent theme. So this is Canada here. And MAIDs, they call it MAID, which is medically assisted dying. And it's been legal since 2016. Started slowly, and it's growing now fast. It's the fastest growth in assisted dying anywhere in the world. And in fact, assisted deaths have risen nearly 8-fold in 5 years and increased more than a third in 1 year alone. Now, some key features are that 85% of Canadians don't have access to publicly funded palliative care. Now, I know I've said that Canada's got a similar healthcare system to the UK, and it does. And perhaps our percentage of the population who don't have access to publicly funded palliative care is less than this, but it's the same theme in that there's a large number who are not getting access to palliative care. And similarly, again, like Belgium, Canada is now 22nd in the end-of-life care rankings, and that's down 11 places since 2015. So the moment assisted dying was introduced, the quality of end-of-life care deteriorates. And less than half of assisted deaths have actually seen a specialist palliative care team. Canada no longer requires a patient to be terminally ill. And as you'll see in some of the research I'm going to present, the governance around the whole area seems very sketchy and deteriorating. And then Oregon, that we've heard about, is the same themes. I mean, you could write the script now, and the script is you have assisted dying, and the ranking in end-of-life care falls. So in Oregon, it's down 34 places since 2015. Again, a very low percentage actually saw a specialist palliative care team. And in Oregon, almost 60% felt a burden, with many stating a fear of pain as a reason for requesting an assisted death. Well, they would have a fear of pain if they don't have access to palliative care, and you can see the tiny number that do have access to palliative care. We see the rate of increase here. So again, it's the same themes in every country. Looking at Canada, because I think it is closest to the UK model, it's had a very, I'm using euthanasia here because there's a very, grey area between them, and assisted dying in Canada can move over to euthanasia in certain cases. But assisted dying has had a very negative effect of palliative care in Canada. And it is a laboratory, it's a clinical laboratory for us to observe how legalized euthanasia or assisted dying can operate in a country with a similar healthcare system to ours. And the following points are just top points written by 5 Canadian specialists about the negative impact on palliative care. And this comes from a detailed research, qualitative research, interviewing clinicians, both doctors and nurses, looking at their perceptions of what's happened since assisted dying was made legal. And they describe an inherent conflict between the provision of palliative care and the eligibility for MAID. So to be eligible for MAID, in some ways, to cut a long story short, you have to withhold certain medications that may impact on an inability to control pain or other symptoms. And this is very distressing for both clinicians and for patients. What's also evolved in Canada is the competition for funding, in that funding is being withheld from services who are not actually providing assisted dying or sufficient assisted dying. It is also noted in this research that mentioning the existence of MAID can be interpreted by the patient as a sort of an invitation to request this. And there's a sense that it's adding to an emotional and existential burden upon patients and families, not just those that want to talk about it or think about it or even have it, but on the other patients in the service. And conversations have become very difficult, both with patients, but also between staff. Serious concerns about the vulnerable have arisen. There's been significant emotional and personal impact on palliative care providers in Canada. And it's very much complicated the relationships within services and between services. Some patients in Canada have come to believe that palliative care means assisted dying, and therefore those that don't want assisted dying are resisting referral to palliative care. This last point is really important, but what's become very clear is that the amount of time having to be invested in actually managing the small number of patients who wish assisted dying, this time is meaning that there's significantly less time for looking after the majority of patients. And palliative care clinicians are quoting that they're now spending more than 60% of their time dealing with a tiny number of patients, and 40% of time is left for the vast majority. The governance of assisted dying in Canada is already not working. Of interest, Toronto Hospital for Sick Children has already drafted a policy on providing euthanasia to mature minors. And this is despite not yet reaching the age of majority, anticipating a change in legislation later this year, which would make euthanasia permissible for these children. And I think this is a very clear example of where things can go in a very short period of time. It is of note that assisted dying is cheap, with Canada estimating that they'll have saved the equivalent of nearly £88 million in 2020. Palliative care is not cheap. While it can be cost effective for individual patients, it's not cheap compared to assisted dying. And many thousands of people around the world who currently cannot access expert person-centered care, that continues, and we can see will get worse. So again, this just reviews the fact that all assisted dying countries have dropped in their rankings of quality of death index since 2015. That's beyond doubt. And we know that BMA members in the UK, the majority, would not be willing to participate themselves in either assisted suicide or euthanasia. And it's not surprising that the detrimental impact of assisted dying on doctors, as that becomes clearer with the psychological impact persisting beyond the assisted dying in up to a fifth of patients, that this is an area of increasing concern. And likewise, the impact on nurses, we've still to understand that, but again, data is emerging from Canada. Finally, just to look at the non-medical model, it is of interest that Switzerland is the only country with a non-medical model of assisted dying, and it's got the greatest growth in palliative care. So, I mean, it is beyond dispute that where you have assisted dying, you have a reduction in palliative care for the vast majority of the population. Apart from if assisted dying is out with healthcare, is something that's in the legal system, there you have the greatest growth, certainly in Switzerland, in palliative care. The fundamental principle of choice is that choice has to be well informed, and we have to have a thoughtful, wise discussion debate. We have to learn from the current evidence. And at no time should we be putting the care of the majority at risk. Current evidence does point, though, to serious risks for the majority of patients with assisted dying embedded in any medical model. The data are completely consistent, repetitive, and going in one direction throughout the world. So I hope that gives you a short summary of where we are from the evidence point of view, and some food for thought, because I think we really can't ignore the evidence as it stands and repeated in so many jurisdictions. So thank you so much.
Many thanks, Marie, for a most informative and detailed presentation again, with various data, especially from Canada. Maybe that's very informative there. It was a great view from the Scottish and indeed an international perspective from the palliative care community.